This is one way in which you can help to end that pay and chase model through pre-bill auditing. This is a disclaimer, and it just simply says that today's information is from my experience, from my research and expertise in the coding profession. But remember, as we go through our webinar today, that the official guidelines for coding and reporting are the only reliable resource for your coders to use, along with the American Hospital Association Coding Clinic, and we will be using both of those valuable resources today during our webinar. Our objectives today are listed on the slide, and I really took a very simple approach to today with a why, how, what, who, and when as to the benefits and the objectives to do during a setup for your pre-bill auditing. So why, that today you're going to learn why do I want to do pre-bill auditing and what will it mean for me and my organization. We're going to go over how to begin doing a pre-bill audit. What do you look for? Who should be doing it, and what is that perfect timing? So one of the biggest benefits of a pre-bill audit, well, the biggest benefit, is sending out a cleanly coded claim out the door the first time. As a coding manager, I always had a motto pinned on my office wall, and it was do it right the first time. So really, that's what we want to do. I don't know whether you're all aware of it or not, but payer auditing has increased 936% in the last 4 years. So we can just rest assured that our claims, as they go out the door, they will be audited. So today is all about bulletproofing and protecting that revenue and preventing the rework. So immediately doing the quality audits of your claims will, after the coding process, you can avoid those red flags that come up for RACs and other payers using their data mining software. So let's talk just for a moment about that data software. They are searching through thousands of claims in only a few minutes. So there's no way that we as an HIM department can possibly keep up with that speed. And that's one reason we need to do it right the first time. In addition, it's important to note, and especially for your CFO as you're talking to him about pre-bill audits, that industry studies have shown that conducting pre-bill audits has resulted in higher reimbursement under the MS-DRG system. So that's important to know also. On slide number 4, let's talk just a little bit about CMS's quality payment program, because as CMS goals of transitioning us to payment value-based will cause us to implement new processes and support the shift from fee-for-service to value-based reimbursement. So I'm going to talk a little just shortly about that today. You're probably already participating in a value-based program, and we know that once Medicare starts something, our commercial insurers are soon to follow. So changing how we do things in HIM and across the revenue cycle is going to be very important in the next few years. As that health care dollar gets leaner, we have to become more efficient. So pre-bill audits are a great way to do that, and that's why I'm so excited to share this information with you today. Here are the basics of the quality payment program. CMS's goals here are really for us to have a high-quality, patient-centered care. And certainly pre-bill audits are part of that patient-centered care because we know that our patients need to have their bills paid by their insurer. The quality payment program is also going to provide very useful feedback, and that's why accuracy is so important. We don't want payers making decisions on inaccurate data because those decisions are going to affect all of us and all of our patients. And then that third block there is continuous improvement. So pre-bill auditing is a form of continuous improvement. And really, I think this year, 2017, is the tipping point for us to begin eliminating errors as we enter that value-based payment world. Here I have my super coder. I love this slide that our marketing department put together for me. I just love it. So reporting under MACRA is going to be a big deal. It's going to involve physician offices, but it's also going to involve a lot of data that comes from hospitals. So we want to collect accurate data. We have to achieve interoperability of clinical information across the continuum of care. And of course, another goal under MACRA is to enhance patient engagement. And there's certainly nothing more stressful for a patient to go through than issues around their bill being paid. So our subject today fits very well in the value-based program world. So collecting accurate data is the key to being successful in the value-based payment world. Patient age, patient sex, payer information, all important data gathered in registration at the very beginning of revenue cycle is part of a pre-bill audit. So not only do we do this pre-bill audit right before we send out the claim, but we actually can begin an auditing process immediately as the patient enters into our electronic system and we start putting in data. So by collect accurate data, I'm talking about the discharge codes, the procedure codes, the DRG assignment, accurate charges, and an accurate bill. So it covers the continuum of the entire revenue cycle that we're talking about today. So clean data is really what it's all about. So for those HIM people on the webinar today, the diagnosis codes, the procedure codes, the discharge disposition, and the DRG assignment are paramount in you're looking for that clean and accurate data. And by reviewing documentation and coding prior to the claim submission, using the pre-bill review process, organizations can ensure physician documentation supports the codes, they can ensure their MS-DRG accuracy, and also this even stretches on further into your quality performance data. The type of data that we're talking about as we gather data through this pre-bill audit process, we're talking about 3 different kinds of data: administrative data, adjudicated claims data, and clinical data. So hospitals, payers, and physician practices and all healthcare organizations collect a lot of data. We all know that. Data comes from multiple sources inside and out of our organization, and that's what makes it so challenging to have all of that data be accurate. We know that the Centers for Medicare and Medicaid, as well as other payers, develop their payment methodologies using that data. It's very important that we be accurate. So I would ask you the question, how accurate is your data? Do you have some numbers that can help you portray your accuracy? Well, if not, that's part of what we're going to talk about today. What information do I gather? What do I show my CFO and prove the value of my pre-bill audit program? So pre-bill audits are proactive, continuous quality improvement. And here I've kind of got my own little quality improvement loop here, where I find the error, I correct the error, I determine the root cause of the error. Is it physician documentation? Is it a lack of coding experience? What's the cause? I then do my educational feedback, and then I prevent and continue to audit so that we don't repeat errors. So that's part of the continuous quality improvement process we're talking about today. And I'm sure you've all been involved in quality improvement processes in your organization. And so that's exactly what pre-bill auditing is. But now the big question that I always have people raise is, well, pre-bill audits take resources. Yes, they do. And I have had many HIM directors ask me, well, how do I approach my CFO and how do I talk about the resources I need to do this? And yes, it does require resources, but it is a very worthy investment. It will require resources in people, processes, and technology to prevent the denials, but it's far more effective with those dollars spent in denials prevention than spending them on managing denials. So as hospitals and healthcare systems pivot from denial management to denial prevention, inpatient pre-bill audits have emerged as an effective reimbursement retention strategy. So let's really start getting into the nitty-gritty of how is coding going to benefit, how are your coders going to benefit, and how is your facility overall going to benefit. Well, for your coding benefits, you're going to uncover missed documentation, coding inquiry opportunities, and you're going to trend those. Promote coding accuracy to drive revenue integrity and provide immediate feedback to coders. So a little history story from me. Early in my career as an inpatient coder, this was probably 25 years ago, I was fortunate enough to work for a hospital that believed in investing in audits. And we were audited by an outside company each quarter. We were given immediate feedback and education about our coding. And that was one of the most valuable things I ever got in my career. And I'm so thankful for it now as I've grown and matured. So know that the pre-bill auditing process will bring coder confidence. Coders will be able to provide a rationale for the coding decisions they make and for the code that they used. That immediate feedback on their coding is a great way to grow your coders from good to great. I can say that from personal experience. So that is some of the coding benefits. Now, the clinical benefits of pre-bill audits are high. The clinical learning is priceless from a patient care and patient safety standpoint. If you can improve the patient safety and prevent one accident or error, it's worth it. So let's talk about the clinical benefits of reflecting an accurate clinical complexity of your patient. So here I'm talking about severity of illness and risk of mortality. And you think about the benefits of portraying that in your documentation in terms of medical necessity and in terms of correct patient status. It's a very high return on your investment. It also will help you pinpoint clinical opportunities for coders, CDI specialists. It will strengthen physician documentation and generate some actionable feedback for your docs. I often have doctors look at me at a very puzzled look on their face when we're teaching CDI, and they say to me, just tell me what I need to document different, and I'll do it. So pre-bill audits are going to generate that kind of feedback for your doctors. And of course, reduce denials and associated costs from claims rework, audits, and appeals. So that covers the why of pre-bill auditing. So let's go ahead now and talk about how. How to perform pre-bill audit. So I have steps number 1 here all lined out for you. Identify your documentation and coding vulnerabilities. So one of the most important things that I can say about pre-bill auditing and about really any kind of auditing in your organization is focus, focus, focus. So here is the activity that you need to do that will help you focus and get the most bang for those resources that you're going to use for your pre-bill audit. Identify your documentation and coding vulnerabilities. So your coders and CDI specialists will be a great resource and wealth of information by letting you know what they see on a daily basis in your records. Also, you want to perform a 30-day documentation and coding assessment to determine CC and MCC capture rates for all of your MS-DRGs, particularly the high-frequency, high-risk, I call them, DRGs. And be on the lookout for common errors that typically result in revenue loss and compliance risk. So you're going to be looking at this list of blue bulleted points I've made on your slide. You're going to be looking for incorrect code assignment in both the diagnoses and procedures. You're going to look for overlooked opportunities for application of the coding guidelines. And this is where your coders need to be experts in interpreting and using those coding guidelines. You're looking for non-specific physician documentation where conditions are suggested by clinical indicators. And what I mean by that is maybe your physician in a progress note has described a clinical condition and giving you some clinical indicators, but he forgot to or neglected to name it. So we're talking about naming it. Compliance risks you're going to be looking for, including code assignment and conditions that lack that clinical validity. So that's just the opposite of the previous bullet. He documented the condition, but perhaps he didn't document all the clinical indicators that the payer would need to really believe that the patient stay was, and patient DRG was correctly assigned. You're also looking, and this is something I find as an auditor a lot, you're looking for errors including of complications of medical and surgical care, including patient safety indicators. So here's your slide 1. Step 1, identify your vulnerabilities. Where do you need to focus? Step 2, focus on your common errors first and incorporate them into the pre-bill process. So anytime you have someone reviewing each chart pre-bill and noting possible missed queries based on clinical indicators present in the record, compile that information using the revised DRG, the supporting documentation, and the coding guidelines and language for a physician query that can provide clarification. Perform within a 24-hour turnaround time, allowing you to reap the benefits immediately. So when you focus on those common errors, you want to be sure that when you give your reports to your coders that you have provided a rationale for that revised DRG. You've also provided them the supporting American Hospital Association coding clinic and the coding guidelines. So this is a great way for them to learn how to use those coding guidelines, and you probably will suggest a query using consistent clinical definitions and criteria that your clinical staff and your CDI people will be able to assist you with. So that is step 2, focusing on common errors first. On your next slide here, I have step 3, 4, and 5. So I'm just going to go through those very quickly. I want to have time for questions and answers at the end. Use your pre-bill reviews to drive concise education for physicians. Physician documentation is key to reimbursement, but it's even more important for patient care. So I just don't like it when I go in and I see progress notes in an EHR copied and pasted until everyone is confused about how to care for that patient, and the communication is just confused. Design targeted physician education sessions that include real-life examples. Provider specialty-directed physician education to help physicians ensure that patient severity of illness and risk of mortality is reflected in the coded data is very, very important for payers and also for our quality program statistics. So really take a look at what can be your education following your audit for physicians. And then also, of course, you want to look at the education to guide the education for coders and CDI specialists. Prioritize topics that can be incorporated into your weekly seminars or meetings to enhance compliance. Because, of course, some of the things that you find in your pre-bill audit will stand out more as a compliance issue than other things. There's also things you will find that will stand out more from a financial standpoint. And those are, of course, the ones you want to prioritize. So here I have a list of what to audit. So some high-risk areas that I recommend you use as you start your auditing for the full benefit. So I'm gonna go through this bulleted list. I'm going to talk just for a moment about each one. Now, this list before you will provide you with plenty of areas of opportunity to get started in your pre-bill auditing. Number 1, high-dollar MSDRGs. Payer auditees are targeting high dollars, and so should you. Dollars matter to all of us. Number 2, MSDRGs with only 1 CC or MCC. So one of the algorithms that payers use to pull these thousands of records within a few moments is an algorithm that chooses MSDRGs with only 1 CC or MCC. And these are called low-hanging fruit. If the documentation of the CC or MCC is not clear and consistently documented throughout the patient's record, it can cause the payer to feel like it's discrediting that code, and they may request that you remove that code, which will lower the DRG. So this happens a lot. An example of that is acute kidney injury documented in 1 progress note. Remember, all diagnoses treated during the hospital stay should be documented on the discharge summary. So I often tell docs, I do a lot of physician education, and I tell doctors, your discharge summary is your hospital invoice. You should be listing all of the diagnoses in your final diagnoses list on your discharge summary. If they don't list the principal diagnosis and they don't list the CCs and MCCs, that is often an avenue for payers to discredit that diagnosis from your coding summary list, and we don't want that. Number 3 here I have listed are MSDRGs with no CC and MCC. Now let me clarify what I mean by CC and MCC. Those are comorbid conditions. So CC is a comorbid condition or complication. MCC is a major comorbid condition or complication. So you want to be auditing MS-DRGs where there is no CC or MCC assignment, because you may find an MCC or CC that was overlooked during the initial coding process, or you may cite clinical indicators that need diagnosis clarification by the physician through query. So this is where you have some opportunity to increase reimbursement in the MS-DRG system through pre-bill auditing. Number 4, long-stay, low-weighted MS-DRGs. They do beg the question, was something else going on? Was it documented and was it captured in the coding? So let me give you an example of what I mean by long-stay, low-weighted MS-DRG. An example of that would be an inpatient for 7 days with a principal diagnosis of back pain. So really, was something else going on to keep that patient hospitalized for 7 days? Number 5 on my list is short-stay, high-weighted MS-DRG. So that's just the opposite. An example would be a 1 or 2 day stay for sepsis. Are the clinical indicators really present and documented? Is there an explanation of the quick recovery in the patient's progress notes and discharge summary? Because often payers will come back at a 1 to 2 day stay for sepsis and say, this patient was not as ill appearing in the documentation to warrant this diagnosis. And so especially here, we would take a look at the history and physical report, and hopefully in the physical exam, you won't find the language normal, well-developed female in no acute distress. You really want to say, see there, if I have a diagnosis of sepsis, well-nourished, well-developed female, toxic appearing or ill appearing. So make the documentation really look and match what the patient looks like. Number 6, diagnosis-specific records. So we all know that there are certain diagnoses that we struggle with, not only with coding them and with providing the right documentation, but even our payers struggle with them, and often we'll send them back to us. So what do your coders struggle with? What are the high diagnoses that you have gotten denials within the past? Also, is there a new surgical procedure being performed at your hospital? Are you absolutely sure it's being coded correctly? Or even maybe you have a brand new coder and you're not sure if they know all the intricacies of coding these complex and challenging diagnoses. So that's why you want to look at some diagnosis-specific records. 7 is unspecified codes, ICD-10 codes. So we know that ICD-10 requires a lot more specificity than ICD-9 did. So if you still have a lot of unspecified codes, that'll be an area that you want to look at. And heart failure, I'm still finding that no assignment for acute or chronic or diastolic or systolic. So you want to watch those diagnoses, because sometimes a more specific diagnosis, as in heart failure, will change that code from not an MCC or CC to a CC or MCC when further specified. Heart failure is a good example of that. Last but not least on my bulleted list, I have MS-DRGs on the OIG and RAC hit list. So all RACs are required to have an issues list on their website, and they will actually tell you what DRGs they're looking at. Every year I always comb through the OIG list to see what they're looking at, because we want to be looking at the same thing. Here's an example. As a surprise to me, Kwashiorkor syndrome is back on the OIG list. Do you remember 2009 through 2012 when there were $1 million of take-back for the use of Kwashiorkor syndrome code for inpatients? And we all learned that that's really a third world country disease. So I was very surprised in 2017 to see it back on the list. So perhaps we do some refreshers with our coders about Kwashiorkor syndrome, but that would be a different webinar. So now that we've talked about what to audit, let's talk about who do you want to be doing that auditing. So it's all about who, and that's very, very important. Your pre-bill auditing program will only be as good as the skills of the person doing the auditing. So more than one person is great, counterbalance each other, check each other. A coder who possesses detailed knowledge of disease, illness, and injury allows him or her to be far more effective when reviewing a medical record and following up on requests. So sometimes experienced coders can transition to be really good auditors, but it does take a certain amount of time and varied experience to hone this skill. It also takes a strong CDI specialist working with coders to cover all of your bases. Organizations must open up the lines of communication between coders and CDI people, despite the fact that the two often report to different departments. Coders are frequently included under revenue cycle, while CDI may be in case management or nursing. Still, the two functions are more successful, intertwined, and learning from each other. So teamwork is really what it's all about when you're doing pre-bill audits. But together, coding and CDI can monitor audit results, including the reasons for denial, the lower DRG payments. Then that auditing team, I call it an audit response team, they're looking at, it consists of CDI specialists, compliance staff, coders, and hopefully a physician advisor. So organize a monthly or quarterly meeting to discuss your audit findings and share compliance ideas. Team members will benefit from information about general trends and specific examples of denials and lower DRG payments. So review all of your, also if you have external auditing going on, review all of your external auditing findings. So who is this auditor that we're talking about, and what's their identity? Well, auditors should have at least 5 years of recent coding experience and a 95% accuracy rate to be considered for an auditing position. Also, lean on the coding and auditing competency assessments to determine readiness. Organizations should think about whether an in-house coder has the skill sets to perform specific types of audits that will be targeted. One example is hospitals do tend to audit sepsis cases, and I'm certainly in agreement with that because sepsis is such a challenging diagnosis. So your coder turned auditor has to demonstrate a high proficiency in coding sepsis. The coder also has to have an open mind and be willing to consider viewpoints because there's a lot of collaboration and discussion that goes on during the pre-bill audit process. So learning to work in that gray world of auditing. Some people believe that auditing is black and white, but those of us who do audit know that there are many gray areas. So your auditor really needs to have the ability to communicate effectively with others, critical thinking, multitasking, all those important things we do in HIM. And not every coder will fit the bill to be an auditor. But I did do a bulleted list for you about an auditor identity, and it does require a pretty high knowledge base about reimbursement, understanding the HIM role in that revenue cycle, certainly requires a pretty high code set knowledge across the continuum of care with ICD 10, CM, PCS, and also CPT, knowledge of the coding process, and understanding the interrelationships between HIM departments. So this is a big list for your auditor's identity. Here I have our little super action figure, and he jumps in front of us and says, "Stop, always self-audit your claims." Formally considered too significant a delay on the discharge not final bill, today's pre-bill audits are making new roads in HIM and revenue cycle workflows. These proactive audits have become important practice in ensuring accurate and timely reimbursement. Under the value-based program, it's really going to be all about us getting the reimbursement we deserve and keeping it. So there are a lot of advantages to making sure errors are corrected up front before the claim is submitted, including improved documentation, improved coding, and regulatory compliance. So I feel very strongly about the message on this slide that organizations should implement a pre-bill audit to reduce the risk of retrospective third-party audit take-backs. There are also other benefits, which we've talked about a few today, to the pre-bill and the self-audit. A lot of people call it self-audit, and that's a fine term too. But you can determine the root cause of your documentation and billing errors instead of just keeping correcting them. Determine the root cause and fix that. Target corrective action and identify potential undercharges. So There's potential for revenue increase here too, as I said earlier. One of the traditional hurdles with implementing pre-bill audits is extended DNSB, which may negatively affect cash flow. So I don't like to talk just about being a cheerleader for all the great things, but also have discussion about what are going to be the hurdles as an HIM director that you may have to overcome to make it happen. So is the message really to the CFO is that although the pre-bill audits may delay claim submissions, the identification of one accidentally omitted complication of comorbidity or major complication of comorbidity will probably justify the addition of a few hours to the organization's DNSB. All righty, here is an example of a workflow, and I really have quite a bit to say about this slide. I'm watching the time to make sure that we get at least 10 minutes for questions and answer period. Once the target accounts have been identified, that's step one, you've identified your target. Ensuring an efficient workflow is critical for the time that's going to be spent and the resources. So your identified cases should be moved into an audit queue to facilitate the review process. Both internal and external pre-bill auditors will confirm the presence of appropriate clinical documentation and assess the quality and content, and then compare the assigned codes with the application of final codes. So it's important to note that your coders and your CDI people do need to have updated resources, coding books, AHA coding clinic references, and of course facility coding policies. So be certain that the ongoing review and training is on the new guidelines every year and that they're part of the denial prevention. Very important. So as you sit down to do your pre-bill audit, start with the phase sheet. Ensure that the information entered by the registration staff is correct. Age, sex, payer, etc. are all important data elements to passing claims edits and preventing denial. So from there, you're going to go on to look at the coding summary and view the MSDRG carefully. So I read the MSDRG description completely. And I keep in mind that description as I review the record, and I ask myself the question, okay, does this really fit? Next, I'm going to be looking at diagnostic statements by the physician and key documents, and we're going to talk about those key documents later in the webinar today. And procedure coding is also an important part in reading the operative report description, not just the pre-op and post-op diagnoses. I can tell you from experience, I often find in reading the operative report description that the operative procedures named above it are not always portrayed in that description. So that's an important piece. Now I'm going to show you some examples of the slide I said previously that said overlooked opportunities for application of coding clinic advice. So coding clinic advice comes out each quarter. It can be a daunting task for coders to keep up. So as you look at the diagnosis for the patient on this slide, we might think to ourselves, if we're not current on all coding clinic advice, that pneumonia certainly looks like the acute condition here, doesn't it? But we have some coding advice that tells us to add correct me, I'm sorry for that, that tells us to resequence the principal diagnosis for this case. So Coding Clinic's third quarter 2016, page 15, which you'll find on the reference slide in case you'd like to read it. The COPD exacerbation with an infection and pneumonia are both present. Both will give you resequence. Let me show you the Coding Clinic. That helps me explain it. Both, as you resequence your codes here, and you're going to make the J44.0 or the J44.1, dependent on the admission, principal diagnosis, and you're going to change the pneumonia to a secondary code. So this will be something that I find frequently coders have not really gotten familiar with this Coding Clinic, and I often find that the pneumonia is sequenced first. So here's the Coding Clinic to help you understand that. I won't read it to you in the webinar today, but important note for your coders. Sometimes at appearance, the code grouping and the code sequencing might appear to be correct, but often there's coding clinic advice to the contrary. So share that coding clinic with your coders if you think that would be valuable. My second example, and I've only done 3 today because of time, is overlooked opportunities for application of the coding guidelines. So though we use the coding guidelines and they're updated yearly, it is also a daunting task to keep yourself completely updated with those, but absolutely essential. So in reviewing this particular record, we found that we could resequence the acute kidney injury to principal diagnosis. Both the pneumonia and the acute kidney failure were equally treated during the stay. Now, the acute kidney injury is a higher DRG of $6,624. Now, I do have to share this coding guideline with you when 2 or more diagnoses are equally meet the definition of principal diagnosis. And I always kind of laugh when I read the first few words, in the unusual instance, because if you're a coder, you know that this happens every single day. So careful look at those diagnoses, think about which ones were present on admission, which ones meet the definition for principal diagnosis. My third example is non-specific physician documentation where conditions are suggested by clinical indicators. So I talked about this earlier, where maybe there's a progress note, and the physician says something like, her hematocrit is low, and he orders a blood transfusion, but he never names what's going on. So you're going to need a query, aren't you? And in this instance, that query will probably be for acute blood loss anemia. You want to give him a compliant query with a list of choices, of course. So you can see that if you do add that acute hemorrhagic anemia, it changes the MSDRG from 330 with a reimbursement of $13,556 to a DRG of 331 with reimbursement of $20,490, which is an increase of almost $7,000. Now, this patient record will fall out on a payer algorithm for only 1 CC. So make sure your coding is bulletproof with clinical documentation of acute anemia due to blood loss on the discharge summary. So this could have been found in several ways by the CDI specialist or coder. Maybe the lab test for hematocrit, the progress note, and also the addition of a non-OR procedure in the blood transfusion. Word of caution with these is that you want to be sure before you would submit this that you have a good rationale and can defend your code choices. So this brings up a good point. This is a very simple case, is it not? And so sometimes people are misinformed and they think that payer auditors are looking for big complex cases, and that's actually not the case. Most payer auditors are looking for low-hanging fruit. So a record that can be quickly reviewed, a discharge summary, maybe a short length of stay, really a simple case can be very quick for them to recruit large dollars. So coding opportunities, I do want to talk a little bit about what those challenging opportunities can be. And the first one I have listed on my list today is challenging diagnoses. So those diagnoses like sepsis, the failures, heart failure, kidney failure, respiratory failure, and others too, most coders can name them for you. Maybe they're malnutrition, maybe they're encephalopathy. These are often challenging diagnoses, and I definitely do recommend a pre-bill audit on some of those, and the two that really come forward to me the most are sepsis and respiratory failure. But of course, every organization is a little bit different. The second coding opportunity that I see here are missed CCs for a pre-bill audit. So here are some commonly missed CCs. Delirium drug-induced F19.921, dementia with behavioral disturbance F03.91, drug dependence F19.20, hallucinations R44.3, and then last of all, R04.2 hemoptysis. So these are CCs that I often see missed during my chart audit. I also see some missed MCCs, and some of those are acute tubular necrosis, aspiration bronchitis, cardiac arrest, coma, acute core-pulmonale, emaciation due to malnutrition, and esophageal ulcer with bleeding are some of the MCCs I often see missed. And of course, my last bullet point on the slide there is incorrect present on admission indicators. These are especially with the assignment of sepsis and other principal diagnosis choices. Here we have some DRG tips with an opportunity, and I chose DRG 177 through 179. So when you have this DRG, you want to read the DRG description, and I want you to look at the principal diagnosis and look for sepsis criteria. Sepsis can often be missed on these DRGs, 177 through 179. Also, look for acute respiratory failure. On the procedure side, for this particular DRG, look for intubation or ventilation. Possible alternatives for these DRGs 177 through 179 are DRG 871 for sepsis, DRG 207 through 208 for respiratory system diagnosis with vent support, and those are often overlooked DRG tips and opportunities. And I have these for a number of different DRGs. I just chose 177 through 179 as an example. Focus on the principal diagnosis, the MCCs, clinically relevant secondary diagnoses and procedures. I do recommend, and this is totally up to your facility coding policy, but when you're doing pre-bill audits, you can de-emphasize the effort of validating every tertiary diagnosis and those diagnoses that rarely add additional detail. A couple of examples are hypothyroidism and hyperlipidemia, although that is totally up to your internal policy as to whether you want to review every single one of those. Review codes with the initial assumption that the coding is correct. Identify any codes which reveal any potential for lacking chronicity, subtype, etiology, manifestation, complications, maybe the stage of the condition such as chronic kidney disease or an ulcer, and also the severity of the condition. An example of that is asthma being specified as mild, moderate, or severe. And of course, keep your eye out for discharge disposition code accuracy, because often if it's a transfer DRG, you might be paid by per diem rather than DRG payment. So always want to check discharge disposition code accuracy. Thank you for your patience today. We only have a few more slides. So as you take up your chart, here are some of the key review documents. Certainly the discharge summary, history and physical report, operative reports and procedure reports, your emergency department notes and reports, progress notes, physician orders, labs, and x-rays. Now, you may even want to add more to yours, and the order in which you review them, I review them with a discharge summary first, but a very good friend of mine who's an excellent auditor always starts with a history and physical. So it's really individual as to what order you review your documents in. Always remember to look at the admitting physician order to see patient status, see that it's signed, dated, and timed and signed by the physician, because you can certainly get a denial for the entire stay if you don't have a physician order. So I can start there also. So we're getting close to the end of my presentation today. I do want to talk about your plan for 2017 to bulletproof your outgoing claims. I think I've given you a pretty detailed description of what, who, where, why, and when. But value-based care will push CDI programs and pre-bill audit programs beyond the traditional focus of CC and MCC capture and case mix, clear across the continuum of care. I believe eventually we'll be doing pre-bill auditing in other places. I know that a lot of physician private practices are looking to coders and CDIs to help maximize efficiency also in their areas for more accurate data reporting and better clinical documentation. And pre-bill auditing can be the foundation for process improvement and compliance across the continuum. So the question always comes up, who do we need to convince? Well, probably your CFO. A recent survey I read that I could cite for you if you want me to, of CFOs showed that more than 1,000 hospital and physician leaders noted that pre-bill auditing as well as clinical documentation improvement is now imperative to a facility's success under the new healthcare value-based program system. So they might be easier to convince than you think. So, of course, you want to measure. This is my motto. If you can't measure it, you can't manage it. Here's my contact information, and I'm going to go ahead and turn the program back over to Molly, our facilitator. In case you have any questions, please feel free to type those into the message box in the GoToMeeting, because I would love to have some questions to answer. So we'll give you a couple of moments to do that. So one question I did receive is someone asked me, well, where do I start? Well, you may want to start very simply. And like I said earlier, really focus, focus, focus is what it's all about. Maybe you want to start with just one diagnosis. Maybe you want to start with a diagnosis of sepsis. And maybe you want to write a performance improvement plan where all of your inpatient records for the principal or secondary diagnosis of sepsis will be reviewed by a second set of eyes. So you can start very small and you can start very simple, and maybe after you get your sepsis process in place, maybe you want to add a second diagnosis. So a good place to start is right there. Maybe you want to look at your denials and say, what's the diagnosis we're getting the most denials for? And maybe that's the diagnosis that you want to start with. But I would start simple. Thank you for that question. I don't see any more questions. On the slide, you do have my contact information. So please feel free to reach out to me with any questions. I can't resist a good coding question. So I'll go ahead and turn it over to Molly.
So there is one question on here. We will be, Martha DeRother, she did ask if we will be sharing the PowerPoint with the attendees, and we will be doing that. Those should be available on Friday. You can go to our website, hrgpros.com/webinars, and that information will be available to you.